MGR Medical University. She is currently serving at Amla Institute of Medical Sciences, Tirsul, where she leads initiatives in policy development, training, research, and antimicrobial surveillance. Her clinical experience spans clerkship and postings at Kongwood Hospital, NG Hospital and Research Center, BRJ Ortho Center, and MAK Hospital. She has authored publications in open forum infectious diseases and completed advanced training through CMC Vellore, CAHO, CDC, and global programs in infectious diseases. Dr. Thomas is an active member of several professional bodies, including SIDP, BSAC, WHO Antimicrobial Resistance Exchange, and the Pharmacy Council of India. She is also known for organizing CME programs, leading AMR awareness sessions, and engaging in public outreach. With this brief introduction, I welcome you, ma'am, for this conference. Welcome, ma'am.
Am I audible?
Yes, ma'am, you're audible.
Thank you. Thank you, Bharadraj, for giving me an opportunity for this presentation. And thank you for a very good presentation, mainly the introduction. Then can I move to the slides?
Yes, ma'am, you can go ahead.
Okay. Myself, Alga, I am a clinical pharmacist from Amala Institute of Medical Science. Today, I will be presenting the topic antimicrobial stewardship in special population. First, we can see what is antimicrobial stewardship. The definition is the coherent set of actions which promote the responsible use of antimicrobials. For what we are using these antimicrobials? Antimicrobials are the drugs which will be used for infections, which is caused by bacteria, virus, fungus, protozoa, parasites, all. So by this definition, we have to use the antimicrobials very carefully, or else it will lead to antimicrobial resistance. Okay. Then this can be applied to the actions at individual level as well as national, global level, and across the human health, animal health, and the environment. This entire action is for preventing this antimicrobial resistance. And this type of activity is called One Health approach. So we are using the antimicrobials in a restricted manner for human health as well as animal health and environment. And this is the core elements for hospital antibiotic stewardship program. First one is hospital leadership commitment. There should be a dedicated member from the management side who will be providing human resources, financial aids, as well as information technology resources. Then second one is accountability. In our setting, we have a infectious disease physician. We have a madam. So she is responsible for the program management and outcomes. Then next step is pharmacy expertise. We have to appoint a clinical pharmacist, ideally the co-leader of the antimicrobial stewardship program, who will help the lead for implementing the efforts for improving the antibiotic use. Then action. These are the activities. There are a set of activities for promoting the rational use of antibiotics. For example, prospective audit and feedback, then pre-authorization. I will be explaining what is this prospective audit and pre-authorization in the further slides, which will be coming. Okay. Then tracking. What is this tracking? Monitor the antibiotic prescribing, impact of interventions, and other important outcomes like Clostridium difficile infections and their resistance pattern. We have to track this. That's we have to identify what is the impact of these activities we are doing. So we have to track these activities. Okay. Then reporting. We have to regularly report the information on antibiotic use and resistance to the prescriber, pharmacist, nurses, as well as hospital leadership. This reporting in our setting, we have a quarterly meeting. Our committee meeting will be taking place where we will be analyzing the data. 3-month data will be presenting within that meeting. Mainly the consultant, pharmacist, then pharmacy operation department, then hospital infection control nurses, all will be presenting in that meeting. So we will be reporting this data, and such a type we can educate those areas. Then education, educate the prescribers, pharmacists, nurses, and patients about adverse drug reaction from antibiotics, antibiotic resistance, and optimal prescribing. Then next slide, WHO aware classification. The WHO has classified antibiotics into three types: axis group, watch group, reserve. This is the abbreviation WARE. We can see this, that's an axis group. It is the first line antibiotics offer the best therapeutic value and they are having low resistance potential. Most of these antibiotics are in or we can be used in oral route. Okay. Then example is amikacin, amoxicillin, clavulanic acid, ampicillin, cephalexin. All these are axis group antibiotics. Then watch group. Watch group, these are the first or second choice antibiotics only indicated for specific and limited number of infective syndromes. Comparing with axis group, watch group antibiotics have high resistance potential. The example for watch group antibiotics are azithromycin, cefixime, cefotaxime, ceftazidime, meropenem, piptaz, piperacillin, tazobactam. All these are comes under watch group category. Then next is reserve. As the name itself, we can understand we have to use these antibiotics very, very carefully or else the MDR infections will be increasing. Okay. Then this is the highly selected, this should be used for the highly selected patients that in the life-threatening infections like multi-drug resistant bacteria. What is meant by this multi-drug resistant bacteria? Of the bacteria which is resistant to most of the antibiotics. So we have no antibiotics for treating the patient. Such kinds of infection is called MDR infection. And that bacteria is called multi-drug resistant bacteria. Okay, then we have to closely monitor and prioritize as target for stewardship program to ensure their continued effectiveness. The examples for reserve antibiotics are ceftazidime avibactam, colistin, fosfomycin IV, linezolid, tigecycline, and polymyxin. These antibiotics, most of these antibiotics are having high cost. Then next is 5 Ds in antimicrobial stewardship. First one is diagnosis, second is drug, then dose, duration, and de-escalation. Then what is meant by diagnosis? Does the condition require an antimicrobial therapy? For example, in case of bronchitis, the bronchitis is the condition which may be caused by both bacteria as well as virus. But in majority of the cases, the bronchitis is caused by the virus. So antibiotic is not indicated in bronchitis. I just said it's for an example. But we have to monitor whether the diagnosis is correct and the drug prescribed for it is also right. We have to review that. Okay. Then diagnosis, does the condition require antimicrobial therapy? We have to check that. Then we have to compare it with the drug. Is the empirical antimicrobial is appropriate or not? Is it the most targeted and the safe antimicrobial? So we have to check the drug, the dose. Okay. I will say one example. One of my day, a patient came with meningitis. Okay. The drug of choice for meningitis is ceftriaxone. Ceftriaxone 2 gram TDS. It will be given as 2 gram TDS. But in rounds, I saw that meropenem along with ceftriaxone plus and vancomycin was administered to the patient. So I conveyed this intervention to the consultant. So she said, we will be giving all these antibiotics. But then I give the guidelines, which is documented as like that. We have to give ceftriaxone plus vancomycin because the ceftriaxone having more CSF penetration when comparing with meropenem. So she agreed to take ceftriaxone and she agreed to stop meropenem. That was an intervention which was done. Okay. So the drug of choice for CSF infection is ceftriaxone plus vancomycin. Okay. So we have to check whether the empirical antimicrobial therapy is appropriate. and is the most targeted and safe antimicrobial. Whether this drug is the most targeted as well as safe antimicrobial, we have to check. Okay, then dose. What is the recommended dose, and is therapeutic drug monitoring is needed for that particular antibiotic? Then duration. What is the recommended duration? Can the antimicrobial be switched from IV to oral? All this has to be checked during our rounds. Okay. Then de-escalation. Is there a narrow spectrum antimicrobial is based on the culture report? Okay. When culture report is available, we have to check there is any chance for de-escalation. For example, meropenem, which is a high broad spectrum antibiotic, we can we de-escalate it into piptas, piperacillin tazobactam, which is a narrow spectrum antibiotic when comparing with meropenem. So we have to look all these aspects. Then AMS interventions. There are different types of intervention. The main intervention, that is the core intervention, is prospective audit and feedback. The clinical pharmacist has to should visit the bedside and review the antimicrobial drug codex. In our setting, we have a separate yellow drug codex where the antimicrobials will be prescribed rather than the other drugs. So we have to monitor those drug codex, and we have to send the feedback to the consultant. If we are seeing any corrections, we have to inform it into the correct consultant in a polite manner, or else it will be a big problem. Then antimicrobial timeouts. Then we have to assess within 48 hours whether in most cases empirical therapy will be in a broad spectrum. So can we de-escalate to a narrow spectrum? Can we switch the therapy IV to oral? All we have to check in this within 48 hours. This has to be done by the consultant. We have to check whether this consultant is doing this or not. That's our duty. Okay. Then antimicrobial consumption analysis. It is mainly by DDD, calculating DDD and DOT. What is meant by this DDD? This is the equation for calculating DDD. That is strength in grams into total units of antibiotic dispensed divided by WHO DDD. Okay. I will say an example. The amoxicillin clavulanic acid, which comes under a vast category, which is commonly prescribed in our settings. So the WHO DDD, which will be a constant value. WHO DDD is always a constant value. So the strength in grams, most often it will be prescribed as 1.2 grams. Okay. So 1.2 into, assume that total units of antibiotic prescribed is 1000. So 1.2 multiplied by 1000 divided by WHO DDD, it is 3. So 3 divided by 3. So the DDD of amoxicillin clavulanic acid, it will be 400. So by applying this equation, we have to calculate the DDD of the antimicrobials. No one is responding. Am I audible? Hello?
Yes, ma'am, you're audible.
Okay. Anyone can ask a question in between the session also. I have no problem. Okay. Then DOT. What is meant by the DOT? DOT means days of therapy. Days of therapy means the number of days for which an antibiotic is prescribed for a specific indication. That is called days of therapy. Then this formulary restriction. The consultant should get a prior approval from AMS team before prescribing the reserve drugs, which was mentioned before. This is called as formulary restriction. Then guidelines and clinical pathway. That the AMS team will develop clinical guidelines. Mainly, we are implementing sepsis protocols as well as MDR treatment protocols, then antimicrobial dilution guidelines. All these will be done by the AMS team. Then next, it is supplemental interventions. Dose optimization. Mainly, the dose is dependent upon the age, weight, then culture reports, the site of the infection. All these are the factors which will be depending about the dose. So I will say an example. Necrotizing fasciitis, which is a skin and soft tissue infection. For that case, normal clindamycin dosing is injection clinda 600 mg TDS. Thrice daily we have to give. But in such type of specific site infections, we have to give high dose clindamycin, that is 900 mg TDS has to be given. That's an example for dose optimization. Then streamlining or de-escalation of therapy. Once in my rounds, I see that a patient came with complaints of CLD, chronic liver disease, along with gastritis. He came to ED and then into ICU. She was prescribed with meropenem with metronidazole. Both meropenem and metronidazole covers anaerobes. Anaerobic coverage is given by both meropenem and metronidazole. So I send an intervention that both is needed for this patient. That meropenem, that's it will be having both gram negative plus anaerobic coverage. So better is to stop metronidazole. So it is better to stop metronidazole, and the consultant accepted to stop the metronidazole. It is an example for de-escalation of the therapy. Then parenteral to oral conversion. Um, when we discuss this topic, the IV therapy, it is little bit costly. So it is better to convert oral formulation when the patient is clinically better. And another one main point is when we are giving the patient antibiotics in oral route, we can mainly prevent the line related infections also. So it is mainly important to convert parenteral to oral formulation. Then laboratory surveillance and feedback. The microbiology department is responsible for providing the antibiogram. Antibiogram means it is a cumulative data where the antibiotic susceptibility against each each microorganisms will be provided, and the susceptibility data, it is a set of data. So the clinicians can choose the empirical antimicrobial for giving the patients can be chosen by this method. Okay, then clinical education and communication, the clinical algorithm for diagnosis. Education and communication, the main method is we have to prepare clinical algorithm for the diagnosis of the patients. Then goals of antimicrobial stewardship: ensure best clinical outcome for the treatment or prevention of infection, minimize unintended consequence of antimicrobial use, such as adverse drug reactions and emergence of AMR, means antimicrobial resistance. Then minimize healthcare costs without compromising the quality of care, accurate diagnostics. Then measuring the outcome, we can measure the outcome by three ways. There are process outcome, patient outcome, as well as microbiology outcome. The process outcome, we will be calculating the DDD as well as DOT, as I mentioned earlier. Then patient outcome, it is mainly the in-hospital mortality, length of stay, readmission within 30 days after discharge. Then microbiology outcome, we have to check the Clostridium difficile infection prevalence, MDR organism, multi-drug resistant organism, for example, with MRSA means methicillin resistant Staphylococcus aureus, which is a gram-positive organism. Then CRAB. CRAB means carbapenem resistant Acinetobacter baumannii, and CRE means carbapenem resistant Enterobacteriaceae. We have to check all these parameters. This is a case. A 63-year-old male patient came with complaints of COPD, chronic obstructive pulmonary disease, and shortness of breath. Then saturation is 80 to 85%, and procal, it is a bacterial biomarker. It is 75, and TC is 23, and chest X-ray shows consolidation. Bowel culture has obtained, and we have Klebsiella pneumonia with significant growth, 10 raised to 5 colony forming per ml. It has been obtained. We can see there is no bacteria, no antibiotic which is sensitive against this Klebsiella pneumonia. So this case, we can understand what is the importance of antimicrobial stewardship for preventing the antimicrobial resistance. Um, Fortunately, there was a synergy present between ceftazidime avibactam and estrianum. But the cost for ceftazidime avibactam per vial is nearly 4,000. The dosing, normal dosing for ceftazidime avibactam is 2.5 gram TDS, that is thrice daily. The ceftazidime avibactam along with estrianum. Estrianum means 2 gram TDS is the normal dosing for estrianum. So ceftazidime avibactam 4,000 rupees nearly. Then that 4,000 three times it will be nearly 12,000 plus estrianum 2 gram TDS, that will be 16,000. Then the average cost per day is nearly 18,000, which is very, very hectic. And moving to the next slide, we can see the importance of AMS in pediatric patient. This is a case. This is a study from coastal Karnataka, South India. We can see the results. Stool samples of 138 children were tested. Out of this, 21 samples were culture positive for Clostridium difficile infections. Then we can see what is this Clostridium difficile infection. The normal gut microbes. There are no, good bacteria within our gut, which is helpful for our immunity. But excessive or uncontrolled use of these antibiotics, which will kill the good bacteria and causes infection. This type of infection is called Clostridium difficile infection, and the 21 samples out of 138 were positive with Clostridium difficile infections, and another another intestinal pathogen isolated was E. coli, and it is about 22.46%. So it is an by understanding the study, we can understand the need for antimicrobial stewardship in pediatric patients. Okay. The physiological development may alter the pharmacokinetics and impact the pharmacodynamics of drugs. The two key factors stemming from physiological maturation that contribute to pharmacokinetic alterations in pediatric patients are body size as well as organ function. This organ function is defined by age. Generally, we are pediatric patients means the age group between from birth to 18 years. There are subcategory among this. That is the premature neonates. These patients who are born before 37 weeks gestation, the neonates within first month of life, then infants, that is 1 to 12 months, then in children means 1 to 12 years, adolescent means 13 to 18 years. These are the pharmacokinetic parameters, that is absorption, distribution, metabolism, and elimination. The pediatric patients, the organs are in a developing stage. Okay, the organs, all organs, mainly the kidney and liver, all these are in a developing stage. Considering the absorption, the gastric pH in neonates is more, gastric and intestinal emptying time is more, then biliary function, pancreatic function, and gut microbial colonization. This is less in neonates when comparing with infants. Then intramuscular absorption, skin permeability, and percutaneous absorption is more. Percutaneous absorption is more. So we can consider percutaneous route for drug delivery. Then distribution. The total body water and extracellular water, it is more in neonates when comparing with late childhood. Then total body fat and muscle mass, it is less for the neonates when comparing with the child. We can consider the child same as the adult, that the child pharmacokinetic parameters is same as that of adult. The total plasma binding proteins is less. Then hepatic distribution and elimination, the cytochrome P450, it is the which is produced inside the hepatocyte in the liver. It is the main enzyme for hepatic distribution and elimination. The cytochrome, there are different subtypes. All these are reduced in or in decreased, there are decreased activity in neonates. Then renal elimination, glomerular filtration, tubular secretion, and reabsorption. All these are lesser in neonates when comparing with adult. Okay. Then another one example is okay. The clearance of antibiotics will be mainly through kidney. Then that is the glomerulus. That is the glomerular filtration is the procedure where the drugs will be eliminated. Mainly, I will be explaining the beta-lactams, aminoglycosides, and vancomycin. Because of this decreased renal elimination, this may lead to increased drug exposure in neonates and infants. This will lead to what that is the risk for toxicity is higher. So the side effect, the nephrotoxicity for aminoglycosides will be seen in our infants. So dose should be adjusted among infants. The next is aminoglycosides and linezolid. Both these drugs are hydrophilic drugs. As we also, as we saw earlier, that is the total body water and extracellular water is higher in neonates. So the aminoglycosides and linezolid, these are hydrophilic drugs. What will happen? Subsequently, there will be increased, for the infants, increased loading dose should be given because the augmented total body and extracellular water content evident in neonates and young infants translate to increased volume of distribution. Volume of distribution is the main factor which determines the loading dose of the antibiotics. So, since these aminoglycosides and linezolid is having are hydrophilic drugs, there will be increased volume of distribution. So we have to adjust the loading dose. We have to increase the loading dose, that is milligram per kilogram. That is the dosing milligram per kilogram. We have to adjust. Then this reverse will be observed for the lipophilic drugs. For example, clindamycin. Clindamycin, which is a lipophilic drug. So we have to reduce the dose or else it will cause toxicity. This is a study from clinical pharmacokinetics from American Society of Health System Pharmacists, which is released in 2012. Then another one we can see that is vancomycin. Vancomycin demonstrate partial binding to albumin with a reported range of 30 to 60% in adults. In adult itself, the vancomycin is having partial binding. So when we are comparing this adult with children, there will be decreased binding in albumin in pediatric patients, results in a significant increase in unbound vancomycin fraction. This unbound vancomycin fraction which leads to toxicity. Okay. These are the guidelines or policies common for pediatric infections, which is provided from American Academy of Pediatrics. First one is the policy statement regarding the antibiotic stewardship in pediatrics, which will contains the guiding principles for appropriate antibiotic prescribing to optimize clinical outcome while minimizing the unintended consequence of inappropriate antibiotic use. Then second one is the Red Book. This is also provided from American Academy of Pediatrics, which is released in the year 2021. Then next guideline is also from American Academy of Pediatrics, released in 2013. This defines the diagnosis and management of acute otitis media and provides the recommendation to primary care clinicians for the management of children from 6 months through 12 years of age with uncomplicated acute otitis media. Then next one is an IDSA guideline for group A streptococcus pharyngitis. The next one is the clinical practice guideline for diagnosis and management of acute bacterial sinusitis in children aged from 1 to 18 years. Okay. Then moving on to the next slide, we can see the importance of AMS in geriatric patients. In geriatric patients, we have to first think about the comorbidities. As increased age, there will be many number of comorbidities and there will be age-related alterations. We can see the pharmacokinetics in aging. About the absorption, there will be reduced gastrointestinal motility and blood flow. There will be increased or decreased gastric acid secretion, which will reduce the drug absorption, whereas reduced gastrointestinal motility may result in more drug may be absorbed. It will be causing a side effect. In geriatric patients, the antacids and overuse of proton pump inhibitors are common. The first pass metabolism may also be increased. Then seeing the distribution, the muscle mass is declining in the geriatric patients and the fat is increasing. Then metabolism, the ADR that requires hospitalization is approximately 10.7% for elderly patients as compared with 5.3% for the general population. It's about the metabolism. Then excretion, the T half. T half means the time taken for the drug to reach the half of the concentration in our body. So T half of the drug increases as the renal function is reduced. In geriatric patients, renal function is, in most of the cases, the renal function is reducing. So the T half will be increasing. The renal function declines. So the decline in blood flow, there will be decline in the kidney mass, decline in the size and number of functioning nephrons. All will be taking place. Then renal changes are predictable. Then this is a report stating that 63 to 70% of people aged over 63 years are prevalent for multiple comorbidities. Then another report by CDC, the Center for Disease Control and Prevention, is also saying that prevalence of 34% of CKD, means chronic kidney disease, is seen among the patients with age more than 65 years. Then antibiotics metabolized in cytochrome P450 enzymes should be used with caution since hepatic mass is decreased in older adults. Yet antibiotic with renal elimination are particularly challenged with age-related glomerular filtration rate. So the antibiotics which is metabolized in cytochrome P450 enzyme should be used with caution in aged patients. And side effects of antibiotics in older adults. A common side effect are digestive, that is mainly causes diarrhea, clostridium difficile infections. It is caused by fluoroquinolones, azithromycin, cotrimoxazole, amoxicillin, nitrofurantoin. Then neurological, cefepime, carbapenems, fluoroquinolones, carbapenem, mainly the imipenem derivatives, that is imipenem cilastatin. Those antibiotics have seizure tendency than meropenem. So nowadays consultants are more preferring meropenem over this imipenem cilastatin. In acute kidney injury, it is caused by vancomycin, cotrimoxazole, aminoglycosides, and colistin. Then arrhythmia, macrolides, tendon rupture is caused by these fluoroquinolones. Then liver toxicity by fluoroquinolones, hematological toxicity by linezolid. In polypharmacy, definitely it is commonly observed in older adults due to increased comorbid condition leading to potentially inappropriate medications. Then American Geriatric Society by a criteria which including they will be updating the list of potentially inappropriate medications that to be avoided or to be used in caution in older adults. It is provided by the American Geriatric Society. Then administration route. Elderly patients so often have poor venous access. So swallowing and behavioral disorders is that's also we have to consider. So it is difficult for administering through IV and oral route. Some studies have suggested that subcutaneous route can be an alternative for administration of antimicrobials. Then moving to the next slide. Then what is hello?
అడివారం ఫుడ్ హిల్స్ ఎంటైర్ వర్డ్ ఇలా
கொஞ்ச நேரம் முன்னாடி பேலன்ஸ்ல கில்லாடி பேசணும்ல
நீதான் பேசுனா
Excuse me. Can I continue?
Yes, ma'am, you can continue.
Yes, ma'am.
Importance of AMS in obese patients. The volume of distribution relates the total amount of drug in the body to plasma concentration is the principal determinant of loading dose. So lipophilicity, it is the main factor in obese patients. Increases volume of distribution is mainly seen. The volume of distribution can be overestimated when we are considering the total body weight. Total body weight means the weight that is showing within the weighing machine. So for hydrophilic drugs, we have to consider actual body weight. The calculation part I will be seeing in the next slide. Then total body clearance, which is the sum of clearances by each of the eliminating organs, primarily the liver and the kidneys. And the increased organ mass in obesity may influence the clearance. The increased renal clearance was attributed to increased kidney mass and renal blood flow in obesity, and it may affect the elimination rate. Okay, these are the equations for body weight calculations. There are different type of body weight: ideal body weight, adjusted body weight, and total body weight. The equation for ideal body weight for male, it is 49.9 plus 0.89 multiplied by height in centimeters minus 152.4. Then in case of female, it is 45.4 plus 0.89 into height in centimeter minus 152.4. Then adjusted body weight, it is ideal body weight plus C, which is a drug specific correction factor multiplied by the difference between the total body weight and ideal body weight. Then total body weight means the actual body weight. Then for each antibiotics, we will be calculating different
equations as I mentioned in earlier slide. So for aminoglycosides, we have to consider the adjusted body weight. That drug correction specific factor is 0.4 for aminoglycosides. And sodium polystimate, that is polystin, the loading dose we have to give in sepsis and in severe infection. If the patient is having weight more than 50 kilogram, the loading dose should be 9 million international units. And the weight, if the patient is less than 50 kilo or equal to 50 kilo, we have to give 6 million international unit as the loading dose. The maintenance dose, we have to give 4.5 million international units BD, or we can give it as a single dose, means OD also we can be given. And for trimoxazole, it is the adjusted body weight and the drug specific correction factor is 0.4. Ciprofloxacin, the adjusted body weight is to be used and the drug specific correction factor it is 0.45. Levofloxacin, we have to use the ideal body weight, and fosfomycin, we have to use the total body weight. While considering vancomycin, we have to use the total body weight, and in daptomycin, we have to use the adjusted body weight. Metronidazole also we have to use the total body weight. Then these slides we will be discussing about the importance of AMS in pregnant patients. During pregnancy, the antimicrobials are often required to treat certain infections. In general, when potential benefit outweighs the non-risk, the medication has to be considered during the treatment for this pregnant ladies. These are the common antibiotics and adverse events which are seen among these pregnant ladies. Aminoglycosides causes ototoxicity. Chloramphenicol causes gray baby syndrome in women or in fetus, which causes G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency, and causes the hemolysis. Fluoroquinolones, possibly arthralgia, theoretically mucoskeletal defects will be seen. Nitrofurantoin in women or fetus with G6PD deficiency. Primaquine, it is an anti-malarial drug in women or fetus with G6PD deficiency. Then streptomycin, ototoxicity. Sulfonamides, when given after 34 weeks of gestation, neonatal jaundice and without the treatment. In women or fetus, may also cause to G6PD deficiency. Then pharmacokinetics in pregnancy. While considering the absorption, nausea is very common during the pregnancy period. Nausea, vomiting is also there.
So there will be difficulty in adherence. Also, there will be uncertain reduction in drug intake. The pregnant ladies will be having reduced gastric emptying, which will cause decreased maximal drug concentration. Gastric pH will be high among pregnant ladies, so the absorption of weak acids and base molecules will be observed. Considering the distribution, there is total body water and expanded plasma volume is high, and there will be high or elevated volume of distribution of hydrophilic drugs. The body fat is also increased in the pregnant ladies, so the volume of distribution of lipophilic drugs will be increased in pregnant ladies. So we have to consider all these factors while seeing the dose for pregnant patients, or else it will be causing side effects or ADR. It will be causing both the pregnant mother as well as the fetus. Decreased maternal albumin and albumin occupied by steroids or hormones, which will be causes increased free drug fraction. Then metabolism, enzyme induction and inhibition by progesterone and estrogen. The estrogen and progesterone will be elevated during the pregnancy period, which will inhibit certain types of enzyme as well as induce certain types of enzyme. This will also change the metabolic pathway of the antibiotics. So we have to consider all these factors. Then elimination, increased hepatic blood flow. There will be increased elimination of high hepatic extraction of drugs. Then increased renal blood flow and increased glomerular filtration rate. This will be causes the elimination of the renally eliminated drugs. So if the drugs are eliminating more through the renal secretion, so the therapeutic effect will be decreasing. This also has to be considered. Then impact of labor, the vomiting and delayed gastric emptying, fluid shift, dehydration, blood loss, high metabolic demands and ketosis, rapidly changing hormonal profile, then interventions that impact on physiology, that is epidural anesthesia. Then importance of AMS in patients with fever and neutropenia. The empiric broad spectrum antibiotic therapy is the foundation of infection management in patients presenting with fever and neutropenia. So we have to select the empirical therapy by considering the next few points: the infection risk assessment of patients, the antimicrobial susceptibility of pathogens isolated locally, then the potential site of infections, then importance of broad spectrum bactericidal antibiotic regimens that include anti-pseudomonal coverage, then clinical instability like hypotension, organ dysfunction. We have to monitor all these parameters. Then recent antibiotic use. In cancer patients, they will be having antifungal prophylaxis, antibacterial prophylaxis, and antiviral prophylaxis. So we have to consider all these parameters and we have to choose the empirical antibiotic therapy. The initial empirical regimen for neutropenia with clinical instability will include broad-spectrum beta-lactam, that is imipenem, cilastatin, meropenem, piptas, along with aminoglycosides and vancomycin. Once we are giving a broad spectrum of antibiotic, after we are getting the susceptibility reports, that is the when the culture report is available, we have to de-escalate. For patients having febrile neutropenia, unresponsive to broad-spectrum antibacterials, the empirical antifungals with activity against mold is initiated after more than 4 days of empiric antibiotic therapy. Okay, then the addition of fluconazole or echinocandins, that is mainly the caspofungin, like that, antifungals should be strongly considered if the patient is not receiving antifungal prophylaxis. So we have to compare whether the patient is having earlier antimicrobial prophylaxis, and we have to decide whether the antimicrobial therapy which is started empirically should be with the broad spectrum or narrow. We have to decide. The duration and de-escalation of therapy depends on the underlying site of infection, positive organism, patient's clinical condition, and neutrophil recovery. These all has to be checked while we are saying for the de-escalation and duration. Okay, thank you. Hello, am I audible?
Yes.
Can anybody have any queries or doubts? I will try my level best.
Yes, ma'am. I have some case related.
Okay.
Ma'am, the case of pharyngitis, uh,
Mm,
I am and was older patient.
mm.
Uh,
Okay.
uh, 55, 55,
Okay. Okay.
56.
Mm,
Uh, the case was of a complication related to that.
mm.
The complication was of streptococcal induced glomerulonephritis.
Glomerulonephritis. Okay. Mm.
Yes. Means after the streptococcal infection, the complication was of that glomerulonephritis. So the question is that we should treat this with the same antibiotic we use in pharyngitis, the complication with increased dose, or we should go for some other alternatives.
Basically, we have to choose the antibiotics based on the activity. Certain types of antibiotics will not be effective for means the kidney infections. So we have to consider that, and we have to escalate or de-escalate. We have to the site specific activity of the antibiotics should be considered.
Ma'am, the question lies is where we should go by that the cause of disease, that complication, or by the bacteria growing there, because when I found that the cause for that is that immune cell mimicry that was causing damage to the glomerular that nephrons.
That means it is not an infection.
Ma'am, it is not infection, but as we mentioned that post streptococcal infection that created the antigen against our own body cells, because
Mm-hmm.
due to presence of bacteria only.
Okay, so we have to give antibiotic, and supportive therapy should be maintained.
Okay, ma'am.
Excuse me, ma'am. Ma'am, with regards to drug-specific correction factor, if it is not mentioned, then where, which website to check? Because there are many guidelines like IDSA and Indian have their own guidelines. Then
Mm.
how to follow? If
Um,
specific drug specific correction factor is not mentioned, value.
Actually, there is no specific guidelines about this drug correction factor. We have to check multiple guidelines have to be checked, and then only we will be getting this correction factor. There is no a single guideline which defines all these materials. We have to refer multiple guidelines, then only we will be getting. That's the answer I want to say.
Okay. Thank you.
Ma'am, second question regarding the empirical treatment of any infection.
Hmm.
If the patient arrives in the clinic in the ward diabetic foot patient, then
Hmm. Okay.
on what basics we should start that empiric therapy, because at first hand we don't have that bacterial culture results.
Okay. Mainly the diabetic patients, the source of infection, that is the type of infection. It may be gram positive as well as gram negative. We can't say blindly it may be gram negative or gram positive. So for diabetic patients, we have to cover both gram positive as well as gram negative. In our setting, we will be commonly giving injection piperacillin tazobactam plus injection clindamycin. And once we can take the sample for culture, and then the culture report will be available. So then we can de-escalate. If the culture identifies a gram positive, then we can stop the gram negative agent, or and vice versa. We have to do for
Ma'am,
diabetic infection. We have to give
in
both
this
coverage.
ma'am, in this case, are there any chances of Means if we give an empiric therapy,
Mm.
there are chances of other bacteria. No, some we are not giving a narrow spectrum, so there are some chances of developing a resistant one.
Uh,
Because
uh,
I have came across this case, the infection was becoming more severe and severe.
so we have to check for the means blood parameters such as procal. We have to check the procal. We have to see the routine blood test. Whether the procal is increasing, we have to escalate. Once if we started with PIP test, if the fever is persisting and the procal is elevating, the WTC level is also elevating, then we have to escalate into meropenem. That is my suggestion.
Okay.
And once the
Thank you.
culture report is available, we have to de-escalate.
Yes, ma'am.
First, start the empirical antibiotic with broad spectrum. And once the culture report and patient is clinically improving, then we can de-escalate.
Thank you, ma'am. Thank you. Thank you.
Any other questions? Hello?
Ma'am, one question from student side. What is your advice for young healthcare professionals starting stewardship work?
Stewardship. We have to go through these ICMR practice guidelines, then WHO guidelines. Once,
விளையாடாத ஐயோ பெடிகிரி கேட்கலாடே
okay, no
Saranya,
problem.
can you please
படுக்க
unmute?
போயில தானாண்டி அம்மாட்ட கேளு
Saranya, can you please unmute?
No problem, no
அம்மாட்ட
problem.
கேளு அம்மாட்ட கேளு
I have no problem with these sounds because I am also having a baby. No problem.
Yeah, ma'am.
What was your question? Okay. Then we are having ICMR guidelines. Then WHO means WHO toolkit. We are having toolkit that is mainly for low and middle income countries. We are having it. That is a document. We have to search in Google. We will be getting that document, and in that document they are mentioning what we have to do. That we have to update our knowledge in our family course syllabus. We are not enough for the antimicrobial stewardship. Once I completed my PharmD in 2021, I was unaware of this antimicrobial stewardship. Then after joining in my institute, we get studied, we start studied. Then we have a infectious disease consultant. She will be guiding what we have to read, what we have to study, all those things. Mainly we have to deal with means MDR infections. So we have to read IDSA practice guidelines. IDSA will be updated the guidelines once in a year for the MDR infection. Without that also there are multiple treatment guidelines are released by this IDSA. Then SIDP, Society for Infectious Disease Pharmacist, is the it is a society. It is an organization from America. It is also helpful for us for guideline updations.
Thank you, ma'am. Thank you for your insightful session on antimicrobial stewardship for special populations. Your detailed explanations, evidence-based approach, and practical strategies have truly enhanced our understanding how to ensure safe, effective, and responsible antimicrobial use. We deeply appreciate the time and expertise you shared with us. Thank you so much, ma'am.
Thank you.
Moving forward, we have another speaker for today, Dr. Rishma R. I would like to give a short introduction about her. Dr. Rishma R., a skilled pharmaceutical product management executive, currently working in Procure Healthcare, Chennai. She holds a Doctor of Pharmacy degree from KLE College of Pharmacy, Bangalore, and brings a strong background in medical writing, product launch strategy, and clinical research. Dr. Rishma has completed internships at leading hospitals including Aster, MS Ramaya, and Aster CMI, gaining hands-on experience in chemotherapy, pediatrics, and liver care. She is also trained in clinical trial processes, pharmacovigilance, and regulatory compliance through her work at Smartech Academy. Her academic and professional projects reflect her commitment to evidence-based medicine, including a study on beta blockers in cardiology and a pediatric case report on purpura. Fluent in English, Kannada, Tamil, and Hindi, and certified in GCP and advanced clinical research, Dr. Rishma is a passionate advocate for scientific accuracy and patient safety. With this brief introduction, I welcome you, ma'am. The stage is yours.
Thank you. Thank you for the introduction. Is my screen visible?
No, ma'am.
Okay, just a minute. Now, is it fine?
Yes, ma'am, it's visible.
Okay, thank you. Okay. A very warm good evening to everyone present here. Myself, Dr. Rishma. I work as a product management executive in medical marketing department at Procol Healthcare Private Limited. Firstly, I'd like to thank RX Doctors team for creating such a insightful conference. Thank you. And